All right, everyone. Welcome to my title's a slightly different here. So, why menopausal runners must prioritize pelvic health and longevity for peak performance. I am really excited for this. And if I can just say, one of the cool things about us doing all these webinars on the menopausal runner channel is I get to almost have a bit of a fangirl moment with people that I follow and really respect within the industry. And I have Dr. Julie, sorry, now I forgot, Wiebe.
Yes. Yeah, Wiebe.
Sorry, apologies.
That's okay.
And I'll do some proper introductions in just a little bit. But I see there's a couple of people who have already joined. Say hello in the chat if you don't mind. Yeah, let me know where you're from. That's always interesting to find out where everyone is from. I see Maria is from not lunchtime yet in California, whereas I'm in South Africa and it's 8 p.m. It's evening time. Yeah, so let us know where you're from. Let us know how long you've been running. Really looking forward to this discussion with Dr. Julie with us. So let me go through some introductions just very quickly before we get into everything. We've got a lot to cover tonight. If you don't know me, well, let's go through that. If you don't know me, my name is Shona Hendricks. I'm the previous former head of sports science at the University of Pretoria. I have a postgraduate degree in sports science. I have an MBA and I'm a certified strength and conditioning specialist. I'm the creator of what we call our Running Through Menopause training framework at coachperi.com. And I'm also a runner and triathlete myself. I've done a number of world marathon majors, a few half Ironman distances, and one or two different ultra runs here in South Africa as well. It's called the Two Oceans Ultra Marathon. Let me introduce our guest, Dr. Julie Wiebe. She has over 25 years of a clinical experience bridging sports medicine and pelvic health. She is passionate about returning active patients to fitness and sports after injury and pregnancy, and also wants to equip professionals to do the same thing. She's a dedicated educator, providing lectures, curriculum, and coursework at clinics, academic institutions, and conferences internationally. And she also has research interests focusing on the interplay between pelvic health and athleticism. So you are definitely in the right place tonight if this is what you are looking for and if this is something that you are struggling with. So Dr. Julie, thank you so much for joining us. I didn't even know, sorry, where are you actually based? We were chatting so much, we didn't even get to chat about that.
I know, I'm actually in Ann Arbor, Michigan, so in the Midwest of the US.
Excellent. Awesome. All right. Well, yeah, so before we get cracking, let's just see, there's tons of people joining. I know there's a lot of our clients. I see Stacy's here. Stacy's in Atlanta, Georgia. Erin, also one of our clients from New Mexico in the USA. Tracy Scott's also one of our clients who's from Durham in England. So really all across the world. So really looking forward to this. Let me add your presentation, Julie. Just see if you flick through that. Yeah, I see. So that's a PDF.
Ooh, you need it big. Now I get what we're doing.
Okay. No. Let's do that.
You keep talking. I'll make it bigger. Hang on.
Perfect. Thank you. So sorry about that. We were so busy chatting before we started. Sorry. We both quite passionate about this topic that we go chatting away. So just hang 2 minutes with us and then we will get you guys. I will keep going through some of the introductions. I know there are lots of our clients on the call. I see Lisa's there and you're welcome, Lisa. Really excited for this. Nikki Mailer, who's from Durban, South Africa. So we literally have all corners of the earth here already. Chandra's in Los Altos, California, and then all the way in Cape Town, Sianda, also one of our clients. I hope Sianda's recovering well. She ran the Comrades Marathon 2 weeks ago. Anne Rutherford from Edinburgh. So amazing. It's so nice to have all of you guys with us. And as I mentioned, guys, this is really an exciting topic, and I'm excited about it because I think women have just been given a disservice, or just over the years, and just been told, oh well, this is something you maybe struggle with, and oh well, just deal with it, or let's just give everyone a blanket advice and just do some Kegel exercises and it's going to sort it out. And Julie's here to really show us and explain to us why that isn't going to be the case. I'm really excited to go through all of this, and I've got a lot to learn here as well. So, yeah, those of you who know me will know that I like challenging some of the norms of the information we give to our female athletes, and so this is very exciting. Yeah, to hear from Julie. Sorry, Julie, are you winning there?
Yes, I'm sorry. I just emailed it to you, but should I re-add it up, or is that?
Yeah, re-add it. I think that'll be good so that you can flick through it. Sorry. No, yeah. So thanks everyone for being patient. Looking forward to this. And guys, let me say this. if you have questions, and this is a topic where I know people aren't going to be so forthcoming with questions because it's a little bit like taboo, right? Like we don't really want to talk about leaking urine while we're exercising. But this is, this is a safe space. And I think, again, this is around changing the narrative. So if you have questions, please don't be shy. Please post them and I will flag all of them and we'll do a Q&A at the end. And then also, guys, if you enjoy these kinds of topics and this is stuff that speaks to you, please hit the subscribe button on the YouTube channel so that we can, give you more of this kind of information. Okay, so I've been babbling a lot. Let me hand over to Julie. Julie, keep going. And if there are questions, we're very chilled and we'll take it from there. Okay,
perfect.
Excellent.
Okay, great. Can everybody hear me okay? Am I good? I lost my voice, so I apologize. It's a little scratchy and it hasn't found its way back yet. But I am. Thank you so much for the invitation to be here, to the Coach Peri team and to Shona, and for all of you for joining. It's exciting to have so many folks coming in from all over. And this is the topic for this evening. We are talking about valuing pelvic health in perimenopausal and menopausal runners. And I love any opportunity to talk to folks about pelvic health and athletics. And so I'm thrilled that you've joined us. And my hope tonight is that we can sort of change some of that perspective, some of the stuff that Shona was talking about in terms of, that it's all about Kegels or, it's all about weak pelvic floors. Like we sort of have heard one story for a long time. So I'm really hoping that tonight you'll leave with some new ideas, new strategies, new tools, but really to sort of understand what you may be experiencing a little bit better. And then just to sort of give you a little bit of a broader piece of the puzzle regarding my own experience or my background is I'm a sports medicine orthopedic physio. So I am not a traditional pelvic health provider. I don't do internal work, don't do biofeedback. My perspective, and I've been at this since my daughter was born. So my daughter is 21, is really, is to look at it from a sports medicine lens, to apply sports medicine concepts to the pelvic floor and to pelvic health needs. And so what that means for me is I look at systems. And so understanding that the pelvic floor is a part of systems. And though that's how we can address it in new ways. Understanding, my hope is that you'll under pelvic control system. It's part of our hip control system. It's part of our pressure management system. It's actually part of our absorption and propulsion mechanism. We actually see the pattern of the way the pelvic floor behaves in running looks just like how the rest of our muscles move through the pattern to absorb impact and then propel. So there's a lot of really cool things that the pelvic floor does beyond something like a Kegel. But we're also going to talk about the value of something like a Kegel, because I know there's a lot of talk out there regarding, Kegels and not Kegels. And so I just want to, sort of give us an opportunity to talk about a lot of those things. These are my objectives, just to be thorough. But really, this is where we're heading. I want you to understand, what are those systems? Like, how do we access those systems? What exactly does she mean by, understanding the pelvic floor as a part of teams? It's a part of all these teams, and then start to talk beyond incontinence. I have been at this for a really long time. Incontinence was sort of our gateway drug into talking about pelvic health in athletics. But we've now had more and more research focused on stress urinary incontinence in the athletic population. But we have other needs. There are other things going on for our athletes. And what I'm hoping tonight is that you'll hear about some of these other things so that you can maybe identify what it is that you need related to what you're doing with your pelvic floor, and why it's critical that you learn to integrate it, or really reintegrate it into these teams to address a broader spectrum of pelvic health needs. And then also, what are your individual modifiable risk factors? When we start talking about something like running is complex. It's dynamic. There's a lot of things going on there. And to think that we could solve an issue that you're having inside running with like one muscle or one muscle group is not really how running works. And that's sort of that sports medicine-y idea. It's really, there's complexity there, but it isn't complexity that we can't untangle. But it's really more like calculus. And so your calculus and my calculus, I join you on the menopause journey myself, but that it's really like our own calculus, and we have to figure that out a little bit for ourselves. And so, so I want to give you some tools to sort of self-assess, like what are some of the things that I might be experiencing, see yourself in some of this, and give you some maybe places where you can start to intervene. What are some baby steps you could take? What's reasonable for you to step into in order to help both your pelvic health, but also maintain your athleticism over time? And then my hope is we'll end with some running relevant strategies. We're going to be talking about the relevance to running throughout, but it's a lot to cover in a short amount of time, so I'm going to fly. But I do hope, and I'm going to stick around for questions as long as we have them. But I really want to just start to reframe and change up like how we're talking about these needs. So it's not that you need to feel any kind of shame at all around talking about this. I have heard it all, and I love to help people because there's not a lot of places we can talk about this. So let's talk. Let's have a conversation tonight. And when I speak, I'm always, this is my new objective, end objective. Every time I speak, I want people to value this in their health as a part of their whole person care. And then I also want folks to really understand the value of someone's fitness of choice. If that, I know we have runners and triathletes here, that is important to you, and it's important. That makes it super important to me. And my job is to keep you moving. And so that's really where we're headed. I do want to just, as far as disclosures go, I do provide online and live professional development curriculum on this and similar content. But this is kind of where we're going to start tonight. This is in the handout. I'm recognizing you may not have the handout, but we can talk about that later. And there's a lot. It's a busy slide. Now that I realize you won't have the handout. But this was a review article that just came out last year that looked at maximizing running participation and performance through menopause. And basically they were like, what do we know? What do we know in 2023? And we've learned a lot. There's a lot more information out there. And basically this is a graphic courtesy of Tom Goom, who's a physio who specializes in runners. That's his hashtag there at running.physio. And he was kind enough to allow me to borrow this for this presentation, and to understand really, like, you're looking at the systems. Hopefully you can at least see the graphic. The cardiovascular system is affected by menopause. We see changes. The muscular system is affected by that depletion of estrogen, and we lose strength, power. The tissue system is affected by menopause. And so what was highlighted here in the graphic is tendons, but tendons are a really dense, thick type of connective tissue. Skin is also a connective tissue, so you may have seen some changes in your skin. But so is fascia. So when you pull apart a chicken, there's that spider webby stuff. That's fascia. That's around our organs. That's around our muscles, and we actually have fascia in and around our pelvic floor and our abdomen and our abdominal muscles, and they're affected by the depletion of estrogen, and it changes how they respond to demands put on them. And same thing goes with our tendinous system. We know that there's changes in our skeletal system. We know about bone density, and we know about endocrine changes, metabolism, mood, sleep, weight gain, all that stuff. And they did include a conversation around the genitourinary system. And in this graphic, there was the graphic talks more about pelvic floor strengthening, again, as Shona indicated at the start, but really they did cover a little bit more in the actual article. But here's the good news, and here's the takeaway from this article that sort of helped us understand some of the things that are going on, and for us as practitioners, how best to intersect, is that honestly, the bottom line is exercise can help it all of it. It can have a really positive influence on current symptoms and helping to maintain your health as you move through time. So our job, my job is, and your personal job is, to keep exercising and to remove as many barriers as we can to you being able to do that. That's my job and my passion. And I know it's valuable to you because you're here. And so the reason that it's so important that we start to find ways to have conversations like this is that we see that any kind of pelvic health condition, pelvic health disorder is what they're referring to here, has and does continue to stop or cause folks to modify their fitness participation due to urinary incontinence. We see about 40% of folks surveyed in this particular study had either stopped or modified their exercise. Prolapse, which is it's the pelvic organs can descend into the vaginal vault. They can impinge on it, and it can actually, you can see it at the exit in some cases, and or it can actually come out of the body, some of the organs, and that can feel like pressure, pain, a bulge, like you're sitting on a golf ball. Maybe this is helping you understand some of your own symptoms. And also anal incontinence, which is really that defines passing wind or passing gas, and fecal incontinence is passing stool. But look at those numbers, 75% and 60% of folks stop or modify their exercise because of those symptoms. And they don't really want to. Half of them in this study wanted to keep running. They wanted to keep doing triathlons. But only 26% of them were screened. Which is actually feels like a really low number, but it's so much higher than it used to be. I've been around the block for a long time, so I'm happy about that, but we have a lot of work to do. And 55% said they'd be happy to talk about it if someone was there for them to talk to. And so that's why these conversations are so important and so valuable. And so, we need to empower you as the athlete with information so that you can start to understand what you're experiencing and have tools to keep moving, and not to have this necessarily shut your athleticism down. But then also, again, my hope is to start empowering coaches and physios and anyone that will listen on how to intersect with these needs. One thing I did forget to mention, because this has the word woman in it, is that I'll actually be using the term female tonight, because my goal is to talk about those that have the female as a biological sex assigned at birth, because we are going to be discussing more specifically the female biology that can lead to perimenopause and menopause and those kinds of symptoms. I know that does not necessarily confer gender identity, so I apologize I didn't say that in the beginning, but this slide reminded me. So addressing pelvic health in our conversations with practitioners, with coaches, and with athletes, we can start to hopefully educate and give tools so that we can keep folks benefiting from exercise as they pass into this perimenopausal and menopausal transition. For the sake of time, I'm just going to say menopause from here on out, so you guys know what I'm talking about. But one of the other things I'm hoping for is that when we talk about this, and likely when you arrived here tonight, you thought, well, I'm going to hear about the pelvic floor, and you are, but the pelvic floor is one part of the solutions. And so when we talk about it, if we change our language and we move away from just talking about the pelvic floor, and we start to understand it in relationship to all of these systems, then we can move our conversation and our thoughts to pelvic health. Like, that's the language I want to use, and I'll be using tonight, because when we only talk about the pelvic floor, then that says only the pelvic floor is at fault or the problem, and then therefore it's our only solution. But what I'm hoping to offer you tonight is a lot of a much more broader conversation as far as that's concerned. And this is something that's out there. I don't know if some of you have engaged in this or seen this on social media, and it's really sort of this, like, it's our personal, our world's Kendrick and Lamar. Kendrick Lamar and Drake battle is to Kegel or not to Kegel. And so I want to clarify that for you, because I really think that all that it's doing is confusing the public. But it has underpinnings in how the pelvic floor functions. And I think that when we understand that, and we understand a little bit more about when we might use a Kegel or not, that might be helpful to you in your own experience. And then also, helping us understand what we're experiencing, how it's related to some of those characterizations, and how we might train the pelvic floor would potentially be helpful to you. And so that's where I want to start, sort of as a way to sort of help our thought process transition to some new ideas. And so really, if you're on Team Kegel, the idea there is that a lot of the reasons that we have understood over time that folks are experiencing pelvic health considerations is that we've said that the pelvic floor is weak or damaged. But a lot of the research that we've had has been on folks that have never had children and they're young. And so it's sort of like, well, how did the pelvic floor get weak or damaged? And so then we think, well, it's the exercise itself might be damaging, which we actually have new information that doesn't necessarily support that, but we're still figuring it out. But we've basically indicated that the pelvic floor is underactive. And I'm specifically using the word underactive for a reason, is that because what I mean by that is that the pelvic floor is not keeping up with the demands that are being placed upon it. That doesn't necessarily mean that it's weak. So again, and some of you that are here may be folks that have never had children, and you are experiencing urinary incontinence maybe while you're running, for example. And so when we start to think about the pelvic floor as something that is trying to meet demand, that sort of changes our perspective a little bit. So let me give you an example. This is how I where's my camera? This is how I like to explain it to folks. This is just a balloon. Here's your diaphragm. And I'm going to go through this a little bit more as we go, but this is your diaphragm. This is your abdominal wall. And then here is your pelvic floor. And so what we actually understand, and I use a balloon because inside our torso, our trunk is at intra-abdominal pressure. And so when we take a breath, when the diaphragm pulls air in, what we actually see, I'm going to show you from the side, is so when my diaphragm descends, it increases intra-abdominal pressure. And what you're seeing is that the abdominal wall and the pelvic floor actually lengthen. They go through this elastic loading that counterbalances that increase in pressure. So we actually have this really cool system that's balanced. It's a team. These folks work together. And so that elastic loading, when the diaphragm lifts and we exhale, we see it recoil back up and in. And so what we're getting there is this interaction between these muscles and the pressure system. And so if, for example, and a lot of you may be doing this right now, sorry, I keep thinking, where's my camera? Is that a lot of us just squeeze our abs all the time. We do a lot of ab squeezing. And so if you look at what that's doing to the pelvic floor below, we're adding force down. And your pelvic floor may be plenty strong to tolerate that through the day. Because guess what? You're doing this in the grocery store line. You're doing this when you walk by a window and you want to pull your tummy in, right? I understand. And so, but what we're doing is we're sort of taking that pelvic floor, no matter how strong it is, to the tippy top of its ability to resist. But then add in a quick sneeze and we get just enough increase in pressure that we leak. But does that necessarily mean that our poor little pelvic floor is weak? Or is it just taken to its extreme so that it's temporarily overwhelmed by the circumstances? And so that's what I'm talking about when I think, like, instead of just saying that it's weak, what's happening that's overwhelming it? And it could be intra-abdominal pressure. So if you hold your breath every time you pick up a load, if you're doing some resistance training, that might overwhelm your pelvic floor. Even if you've done 1,000 Kegels and it's so strong, in that moment, it may be overwhelmed. And so the other thing that we can kind of think about is for a lot of our folks that are running and they're experiencing leaking while they're running, if they're running with their abdomen held tightly and they're running, and remember that pelvic floor is like hanging in there, and then add in the impact forces of running, and that poor pelvic floor is like, I'm out, I can't handle it. And so then we might see leaks, okay? And so again, that doesn't necessarily mean weak, but does the person potentially need some strengthening? Absolutely. Are Kegels fantastic for helping you feel the pelvic floor again, make connections, learn how to embrace this team and get it? Absolutely. So I'm not anti-Kegel, But the flip of that, and if I could have my slide back, is team overactivity, or sorry, team not to Kegel, which is the idea that the pelvic floor can actually be overactive. And so what we actually see for some folks, so let's suggest that we have someone who's running, and they're they run and they leak. All they've ever heard about is a Kegel. And so they may say, oh, I know what I'll do. I'll run. And or they're told to do this. I'll run with my pelvic floor engaged because I know that I'm supposed to strengthen it and hold it. And so now they're going to run like this with their pelvic floor engaged. Well, eventually, if I told you to hold any muscle for a 10-mile run, you would fatigue. And so eventually it isn't able to keep up, and then you might get your leaks. So that might be someone who is overactive, and they've done that consciously. Okay, so we might see someone who is overactive. They've created like almost too much tension in the pelvic floor. So asking them to do more Kegels isn't necessarily going to solve their problem. And the other thing that we've learned from some of our research, and this is that subconscious piece about how the pelvic floor works, is that we know that when the tummy, sorry, I keep going to the wrong, is when the tummy contracts minimally. So just a little squeeze, the pelvic floor does minimal. Tummy, mod pelvic floor, max tummy, max pelvic floor. So what that means is when we are squeezing our abs all the time as we walk by windows and in the grocery store line and while we're exercising, we are inadvertently also activating the pelvic floor to be held more stiffly. And that's really important for us to understand, because guess what? These folks leak too, which may not make sense because you think, well, the pelvic floor is working hard, but the pelvic floor and the tummy, we actually have one study that has shown us that when you do like a light brace and jump off of a height, we saw increased impact forces. So that's a big part of our conversation tonight. We need to be able to absorb impact. That's how we're designed. And so when we hit the ground running this stiff, we don't have there's no margin for the pelvic floor, for that central control system to respond to the demand of that impact. So I like to think of like the bicep. If I'm already here, if you're already held this stiffly while you're running in your trunk, and you get an impact force that you have to respond to, you have no margin. You have no ability to respond to that. And that's not you consciously, but your brain, your system. And so we've sort of shot ourselves in the foot, kind of. And so if we tell someone who's already like this, I'm so sorry, like this, we just need to do more Kegels, that's where the not to Kegel camp is like, no, we can't do that. And so it's understandable, like the intentions of both teams is good. We want to be able to provide folks with the appropriate use of their pelvic floor in their systems. However, it's really important that whenever you hear a binary choice of don't ever do this or don't ever do this, is usually the truth is somewhere in the middle. And that's where we need to start revising our goal for Kegels or any kind of pelvic floor activity. And really the idea for me is I want to help you have a robust, engaged pelvic floor appropriate for the demands that are being placed upon it. So again, if I have my person that's running and they're leaking when they're running, but they're running 10 miles, and I need to train the pelvic floor, not just for strength, which is really what the Kegel is intended for. I need to train it for endurance. I don't need to just train it for endurance. I have to also train it to absorb impact. And a stiff pelvic floor is not going to help me do that. A stiffly held pelvic floor is not going to help me do that. So I'm going to try to coordinate it, teach it how to go through that absorption propulsion cycle. I want it to be well partnered with its teammates, and we have solutions that can help us do that. So again, the Kegel has its place, and so do solutions and strategies that help us help our athletes like you meet the demands you're up against. There's more options out there. It's really cool. And we also need to move away from the idea, and we really are in physio. And I know that if you're in strength and conditioning, you understand this too. Like, one muscle doesn't solve the problems, all the problems for anything that we're up against, especially with someone who is engaging in the complexity of an activity like running. There's a lot going on. A lot of muscles are working. One muscle is rarely the culprit. And so our best practices are to move into thinking about how the systems are interacting and reintegrating your pelvic floor into sport-specific movements and demands. So that's what we're really talking about. How are we going to reintegrate it? And we need to do that with a few ideas. And one of them is to move away from this either or and start thinking both and. Why is that person leaking on those long runs? If they're telling me they're leaking all the way, all 10 miles, that's different than if they start leaking at mile 9. Those are two very different athletes, and they have two very different needs. And so my job is to think through, well, what's happening for them at mile 1 versus mile 9, right? And so where do I see things that I could intersect with? One is the pelvic floor, but I'm
Just checking. Sorry, I think we lost you for a second there.
Oh.
Sorry. Yeah, just literally a second. So yeah.
Okay.
Well, maybe it was just me, but I lost you at around when you said mile 1 versus mile 9.
Oh, okay. I didn't say much else after that, but but what I'll say again, in case, is that at mile 1, if someone's leaking at mile 1 versus someone who's leaking only starts at mile 9, those are two very different athletes. They're two, not that one is more athletic than the other, but their needs are different. And so their program should be different. So just saying, oh, you both need to do Kegels because you're leaking while you're running doesn't really make sense. But so I'm going to look at the pelvic floor and so I'm going to look at pressure systems. So we've looked at that a little bit already. We understand that this is actually how we control our center as we move through space, this interaction, and we're going to talk more about that. We actually can look at how they're controlling their hip because there's interaction there between the pelvic floor and the hip. I'm going to talk to you more about that. What are they doing in terms of their exercise habits? How are they running? What's happening? Is the person who's running 9 miles, is it because their conditioning program got them there, and our person running and having leaks at 1 needs better conditioning to get them to be able to do that? How are they impacting? Can I reduce their impact forces? Things like that. So there's a lot of other tools that we have now in our arsenal to help folks and to think it through for an individualized, tailored program for you. And I'm going to give you some things to think about so you can maybe work through some of this on your own. But I do think it'd be great to always work with someone if you have access to that. But hopefully tonight you'll walk away with some of these ideas. What are some of these other variables we can consider and interact with? And one of the biggies, y'all, is sleep. Okay, especially for our menopausal folks. So that we're going to talk about a little bit more. And on top of everything I just explained to you, we have all the added challenges of perimenopause and menopause. And for many folks, they either have a new onset of pelvic health needs at menopause or during that transition, or something they've already been experiencing is exacerbated by the depletion of estrogen. And all of those issues that we talked about, connective tissue, which is fascia, that can impact some of the control we have of things like the pelvic organs. It also, the muscular density, that the muscle mass that we may lose will help with shock absorption, period, throughout our whole body. And so there's a lot of these pieces, but the other thing that we often see as we make that transition is things like painful sex, which is for some, that change is that the de-estrogenation, sorry, I'm tripping over my words, of the vaginal tissues can lead to dryness, which can make it more painful for penetrative sex. And so estrogen may be a great solution there. It is out of scope for me to give you any recommendations there. However, overactivity of the pelvic floor, we often respond to pain by And so then you've got an overactive pelvic floor. And so we have kind of a dual issue there for folks. And if that person now has developed leaking while they're running and some hip pain and they're having painful sex, we got to untangle that knot a little bit. And just throwing estrogen at it may not be all that's needed, but just throwing Kegels at it or no Kegels isn't necessarily the answer either. We got to look at that whole person and all of that context. So as you're thinking, okay, so where am I in this continuum? I just want to give you a bit of understanding that as a clinician, and I'm not sure that I said this, I think I did, that I'm not an internal physical therapist. Or a physio. And so I look at all of this through external pieces of the puzzle. I look at it through fitness and movement, but I also look at symptom clusters and symptom patterns. Things that we often associate more with underactive pelvic floor or some of those fascial structural things that might be affected is urinary incontinence. So those are leaks while you're running, pelvic organ prolapse, fecal incontinence, anal incontinence, fatigue-related symptoms. We talked about that. Intra-abdominal pressure overwhelm, talked about that. Some of those impact forces. That's where we think the pelvic floor may not be keeping up with the demand. Could be weakness, could also be some of these other pieces that we've talked about. But we also see, and this is what we don't talk about a lot, and I want you to start thinking about, is this you? Are you experiencing urinary urgency? That means you got to go to the bathroom now. And then sometimes what happens is you get there and you kind of just peed not that long ago, but now you're peeing and it's like a tablespoon. And it's like, so then we get urinary frequency. Those are kind of interconnected. Has your stream weakened? That can be one of the symptoms. And again, these are symptoms. They aren't necessarily diagnostic because there are other reasons why that might be happening. But with defecation straining, really pushing hard on something like constipation, we actually end up fighting our own pelvic floor sometimes. And that's a whole nother conversation. But some of these, again, and dyspareunia, that is a fancy word for painful sex. And so again, we might have, let's say, de-estrogenized tissues that make sex suddenly penetrative sex painful. So we respond to it. And then if we never sort of learn how to understand and untangle that, then we may repeatedly have that overreactive pelvic floor, and that can lead to pelvic pain, low back pain, hip pain. And so we have all of these pieces, but we can also see urinary incontinence and fecal incontinence with that overactive pelvic floor situation. And we talked about that with that stiffness. So these are the topics that we don't have a lot of conversation around, but I want to broaden that because this is where we may start to see some of that we evolve into some of these symptoms often when we make that transition into perimenopause and menopause. And so just really quickly, I want to just share, these are some data from my own research. I partnered with a running researcher in Vancouver, whose name is Dr. Chris Napier. And we took folks, he recruited from the local community. Folks ran on a treadmill and instrumented. We got biomechanical data on them, how they're running, kinematics, kinetics, things like that. And then we offered them the opportunity, if they wanted to fill out pelvic health surveys. And so it was a really cool opportunity to look very purely at a running sample of the population. And what I mean by that is they weren't recruited because we were looking for pelvic health issues in runners. They were recruited as runners. So we have this sort of interesting sample that might be more reflective of what's out there. I can't say that for sure. However, when you recruit for a study where you're telling folks you're looking for at pelvic health, you may attract more people with pelvic health issues, which inflates your numbers. I'm being a research nerd right now. But anyway, so I'm kind of excited about the way that we recruited here. But why that's really interesting is some of those symptoms that we often see associated, or issues that we see associated with underactivity of the pelvic floor, like pelvic organ prolapse, fecal incontinence, running-related urinary incontinence, those leaks of urine, we actually got pretty low numbers. Usually what we see is for like running-related urinary incontinence is more like 30%. And so this was sort of surprising. It conflicted with my own bias. It wasn't what I was expecting. We do know that folks potentially self-select, like that first slide I showed you, we see folks leaving an activity like running because of their pelvic health consideration. But we also have information that's shown us that we think there might be a training effect to running. And I'm going to touch on that later. So it's a little hard to interpret this, but it was definitely lower numbers than we expected related to underactivity. What we did see, however, was high numbers of folks that were expressing issues related to overactivity. And so dyspareunia, that's painful sex, we saw 44.6%, which is was high. I was expecting overactivity to be high, but we also saw, you can see here, urinary frequency, 48%, urinary urgency, 60%, weak stream was 36%, defecation straining 49%. So we saw some really high numbers around overactivity. And for me, I work in this space, I was not surprised. This is a lot of what I see. And with my female runners, but I think there's more to it. Like a lot of my female runners also do tons of crunches and they run with their abdomen tight. And so we're seeing that sort of now, if you contextualize it, and hopefully I'm not talking too fast, and this is sort of making sense as we build our understanding of this, there's a lot of reasons why we might be expressing more overactivity in this population. And my oldest runner in this study was 74. And I had folks running from all ages. It was a really cool, I still have so much data to process, and a lot of it's on my menopause folks. So I'm kind of excited to get some more work done there. But often we've been told, that's the other thing, if you have a pelvic health consideration, you should just stop running. I stopped telling people that years and years ago when I realized no one would listen to me, especially runners. They want to run. And that's why I wanted to start developing some of these solutions. But when we understand that there's other elements, other teams that the pelvic floor is on, we can influence the behavior of the pelvic floor through some of these teams. And so we're going to talk about those because that gives you, I don't want to make it sound like it's more complex. What it really is it's actually giving you more ways to affect and intersect with your pelvic health beyond just your pelvic floor activities specifically. I just realized that because we're using a PDF, this slide's not going to move. This is this really cool GIF. Shoot. Boop-a-doop. It's okay. I'm just thinking, what can I do? But it's fine. I'll just.
Sorry, Judy.
No, it's okay. It's like I'm figuring it out in real time. So if this GIF was moving, it would look like what I demonstrated demonstrate what I was showing you with the balloon. But actually go ahead and pull up the slide. I want them to see it kind of in an anatomical way. So if this GIF was moving, what you would see is that the diaphragm is descending. So this is your diaphragm. Here's the abdominal wall, and then this is the pelvic floor. And so again, these are your abs, and this is your pelvic floor. And what it looks like on the GIF is that as we come down, we see that it's a lengthening, and it's a broadening of that abdominal wall and the pelvic floor. And it's really important for us to appreciate that lengthening that we see there, and this. We call it an eccentric contraction. We see a lengthening of those tissues. That's how our body is set up to absorb impact, and specifically with running. And so let me just show you this. And so actually, if you'll put me full screen, then I can see if I'm in frame. I tried to organize my office so that I would be. Oh, gee whiz, I'm so sorry. Okay, so if we understand this related to our glutes, let's talk about a muscle we're more familiar with potentially. So if this is my glute, okay, and when I'm going to run and put my leg out in front of me, oh, my hand is in the way. Sorry, here we go. Okay, so my glute is shortened. Here we go. My glute is shortened here. And then when I go to reach for my foot contact, it lengthens. Can y'all see that? So it's short when I extend my hip behind me, and then when I go into putting my leg in front of me, it lengthens. So when we lengthen, that's how the body sets itself up to absorb your foot contact, that impact. And then immediately when you make foot contact, it starts to move into a shortening contraction to help propel us. Okay, so it helps us absorb when it's lengthened, and then it shortens to help us propel. And the really interesting thing about the GIF, and hopefully you can kind of see it in my balloon, is that it is that same lengthening process that we see for the abs and the pelvic floor. It's not quite as dramatic as it is on the GIF, but you can see that lengthening response. And we actually have research that have shown us that that is how the pelvic floor responds, similar to the glutes. I'm going to show you that here in a minute. Okay, and so it's really excuse me. So restoring that ability for the tummy and the pelvic floor to go through that lengthening is a way to start reintegrating the pelvic floor into an absorptive propulsion cycle that we need in running. This slide just, it basically shows you what I've been showing you here, that we see that descent of that diaphragm, intra-abdominal pressure increase, lengthen, and then on exhalation, we see it recoil back up. That's really how we set up control of our center. So stuff like tummy gripping is sort of interrupting how we're using that whole system. And so that's one of those places where we can start to change up what we're doing with our pelvic floor and learn how to use it within these systems. This is an anatomical slide. Shout out to Essential Anatomy, which is where I got these pictures from. But this is this is your pelvic floor here, and part of it. And what I want you to take note of, I hope this is big enough for you on your screens. This is this is a muscle called the obturator internus. It's one of our deep hip rotators. And it actually has a physical contact with the pelvic floor. They literally intersect with one another anatomically. And then we fill in the rest of the pelvic floor here. But what you're seeing is that the pelvic floor has a direct anatomical relationship with the hip. So if you're a runner who is also experiencing hip issues, stiffness after a run, tightness, pain, discomfort, and you're having some kind of pelvic health consideration, anatomically, those are linked components, okay? And as we fill in some of this musculature, this is over the part of us called the sacrum. So this is that triangular flat bone at the top of your booty, at the end of your lumbar spine. That's called the sacrum. So if you have SI issues, that's the S of SI. And so that what you can see, so go ahead and flash back, is that we're seeing all of these lumbar, low back and back muscles, trunk muscles attached to the sacrum. The pelvic floor attaches to it too. And so we're seeing all this anatomical interrelationship between low back, hip, and the pelvic floor. So pelvic health needs, we actually see low back, pelvic, and hip pain as a interrelated issue for so many folks. And often they go to see their orthopedist or their primary care for their low back pain and hip pain, not realizing that the pelvic floor or a pelvic health issue is intertwined. They may be aware that they're experiencing those pelvic health considerations, but they don't realize how intertwined it is with the function of those anatomical systems. So that is really important. But this is some of that research that sort of elucidated for us the understanding that the pelvic floor goes through this same absorptive propulsion mechanism as the glutes. And so when we go through running, remember your glute is lengthening on that to bring your leg forward. The pelvic floor, what they saw in that first study was that the pelvic floor actually also lengthens, it descends in preparation for that foot contact, and then right at foot contact, it comes back up. And so it does exactly what we talked about with the glutes. It goes through that same cycle. And the interesting thing about that was that that study actually showed the same pattern for both continent and incontinent runners, folks that had no leaks and folks that leaked no matter what speed it was. So again, it's not just the running that's causing the problem. It's not just the impact forces. There's lots of systems in there that we could consider that might help us understand how to maximize and optimize pelvic health inside running. It's not just because that pelvic floor was weak. It's not just because of impact forces, but we do see that that's the pattern the pelvic floor takes. So kegling throughout a run does not match how the pelvic floor actually behaves in running. We also have some good research here around how the glutes and the pelvic floor interact. You've seen them now anatomically, but we actually have research that has shown us that when you strengthen the glutes, you actually see an improvement in pelvic floor strength. And then this study showed us that, again, remember, urgency and frequency are symptoms of overactivity. And we see more overactivity when the glutes are weak. And so, if we understand that those are so intimately interrelated in their function, we might understand that if the glutes aren't kind of shown up for work, the pelvic floor might need to do more. And then this is also another study that showed us the pelvic floor is part of how we dampen our vibrational forces that come up the shank. So the pelvic floor is important. And so we got to help it learn to absorb. And then this is a more recent study that's shown us even more interrelationships between the glutes and the pelvic floor complex. So what can we do? We're running up on our time here. And that's what I want to leave you with. And it's just sort of like, what does all this sort of boil down to? And where I want you to start is to sort of self-assess. Are you experiencing pelvic health related issues along this whole spectrum? Are you experiencing exercise-induced leaks, or maybe that pressure or pain that might indicate you have a prolapse? Or do you only have issues when you cough, sneeze, laugh? That might change what we need to do for you. When are you experiencing those symptoms in your run? Is it in the early, middle, or late part of your run? Has it changed since you hit menopause? Like, that's a really, like, are you doing exactly the same thing you've always done, same run? Or is menopause changing? Has that sort of flipped a switch? Then we need to start thinking through, like, what are some of the symptoms you're having with menopause? And we'll keep talking about that here as we go. But or you're only having symptoms when you increase your distance or your speed? That is another way of kind of considering what we need to be working on. Abdominal behaviors. And what I mean by that is, are you someone that's trying to grip your abs all through your running? Are you gripping it at the grocery store? Let's learn to use the pelvic floor and tummy and breathing as a system. And really what that looks like, if you were going to do it with me right now, we would inhale, relax our tummies, and let the pelvic floor relax. Exhale, and then the pelvic floor and tummy come in. It's literally this like ebb and flow of the musculature and the breath. And then one of the other things we really want to be on top of is bowel health. Are you constipated? Are you straining when you are on the toilet? And so, like, that kind of stuff really pushes and puts a lot of pressure on these structures. And so managing constipation, increasing your fiber, things like that would be a really valuable thing for you. How is your sleep? I am right there with you in my menopause journey. Sleep is the hardest thing. Are you giving yourself adequate recovery? And that doesn't necessarily mean like time between sets. It could be that you're not recovering well because you're not sleeping. And so, so the problem isn't necessarily the time between sets. It's we got to solve the sleep problem. Stress, that's a toughie. Hormone supplementation. What are your beliefs? Were your mom and grandma leak? Did they leak? And if that's true, they didn't have access to all this research. They didn't have folks that really understood this related to any of these pieces of the puzzle. You can have a different future. But for some folks, it doesn't really bother them. But guess what? You're here, so it probably bothers you. And, are you doing resistance training? Are we adding to our muscle bulk to help with some of that shock absorption? Can you vary what you're doing to not get such repetitive loading on your joints and your pelvic floor and your musculature? Are you fueling well? These are just, and some of this is just really great running management. Like, it's not so different and it's not so foreign, you know what I mean? And so applying those ideas would be a great idea for you with all of these pieces. Pelvic floor specific, learn to lengthen and shorten your pelvic floor, just like we talked about, doing it alongside breathing. Inhale, relax your tummy, allow that to lengthen. The pelvic floor can help relax better when you let go of your tummy. Let it learn to absorb shock, go through that cycle. We can also strengthen it that way. That is essentially lowering and lifting for a Kegel, but we're just going to do it in the midst of the system that it works within. We're going to train that pattern. We can strengthen it there. We can work on quickness. But when we learn to let go, we can actually impact those symptoms of overactivity. We can balance that contraction versus just be at one extreme or the other. Reducing, and that can also help with low back pain, low back like stiffness, hip pain, stiffness, and reducing your tummy gripping. Y'all, we've just been sold a bill of goods on that. There, we can have great looking abs and actually let them go. And I don't mean like flop them out, but they don't need to be held navel to spine. And using them in a rhythmic way can be really beneficial for a lot of the things that you might be experiencing. Managing your pressure, we've talked about that a little bit. Hydration, drink. Don't not drink so you won't leak. That actually concentrates your urine. It makes your constipation worse, and that can add to urgency. It makes your urine actually really irritable. And same thing, we know that if you have a rectum full of poo, it's going to press on your bladder, and it can also increase your urgency and frequency, and it can contribute to leaks. So managing constipation is a really important thing. Fiber, and that's what they'll tell you with menopause too. And stress, y'all, I don't know how to eliminate that for any of us, but breathing. One of the things we often recommend is breathing, right? Take these deep cleansing breaths, calm down, blah, blah, blah. But if you're gripping your abs, so everybody make your abs really tight, take a really big breath. Okay, that's hard to do when your abs are tight. Now chill your abs out, just relax them, let them go. Now try to take a breath. So when we dose breathing for stress management, if that person is gripping their abs, the breathing is more up here, it's in your chest, it's tight, it's not a full breath, but it may be a breath you're used to because you're used to gripping your tummy. But that is what we call a sympathetic drive breath. It's a fight or flight breath, and it drives cortisol. Cortisol is the stress hormone. It sensitizes us to discomfort. It might sensitize us to some of our pelvic health symptoms. And it is a stress driver. It is the opposite of what you're gunning for. So understanding your balloon, your own personal balloon, is a way to start maximizing some of the ways you're trying to manage your stress. And cortisol, we think, has to do with some of the ways that estrogen affects some of our metabolic pieces of the puzzle, etc. So remember, we're going to think both, and we want to think about not just pelvic health, but thinking about reintegrating the pelvic floor into these activities, reintegration and understanding how some of the things we're doing to build our athleticism back helps our pelvic floor. So we actually know that adding resistance training, we want folks doing resistance training, period. It improves your running economy. I ask folks in my world that I'm working with to focus on glutes, and hopefully you see why. Glutes, we know that they are big shock absorbers, and if they're doing the shock absorption, the pelvic floor doesn't have to do quite as much. I love that interrelationship, and balancing that relationship between the glutes and the pelvic floor helps me address wherever my patient finds themselves on that spectrum between underactive and overactive. It also helps us build lean muscle mass, which we know helps us with maintaining strength, power, address metabolic changes, etc. We want to prepare for impact. If I'm giving you all these ideas and it's just not working and you're one of those people that leaks start right out of the gate, I want to help reintegrate the pelvic floor and this whole system into your impacts. And I'm going to show you how to do that. So you may need other types of interventions. Always I'm recommending hormone consults, not because it's out of scope, but we do have some new solutions out there, folks, so that's worth looking into. In terms of reduction of impact, I actually like leaning. Sorry, I'm looking at the clock. I'm sort of speeding up here. Leaning into the run. I do that from the ankle, not from the waist. And you're kind of seeing that here. This is one of my athletes who's learning.
William, sorry, don't rush. So take your time. Like, I mean, obviously people have to maybe leave and go, but please don't rush. I think the information is so valuable. So please take your time.
Okay, cool. I am coming to the end, and these are like, a lot of this is stuff that, there's more than what can fit into a short webinar. But I like helping folks lean like they're running into a strong wind. And so I often have my folks practice on a hill, running uphill. That might not be great if you have shin splints or if you have some kind of tibial bone stress injury. So just be aware of that. Again, I got to treat your whole person. But if I'm trying to retrain your ability to get your center of mass over your lead leg, that actually reduces impact forces. And you can see the difference here. This is the same athlete. And when her foot is landing way out in front of her, it's almost like it's stopping her progress every time. And we know that has high impact forces. And when you have the body, the center of mass, the body weight more over the lead leg, and you can't get it all the way over, but toward the front, then we actually see a reduction in impact forces. Naturally, that creates an increase in cadence. We know increases in cadence also reduce impact forces, but I have that here as one of your options. I actually don't love just straight up increasing cadence for folks. And the reason and this is with my population. So folks that I'm seeing that have a pelvic health need and a musculoskeletal need like low back pain or hip pain and a performance need. So that's my population, folks that need pelvic health, musculoskeletal, and performance, like that combination. And so those folks, which may be all of you, I prefer leaning because I get that natural increase in cadence. It speeds you up a little bit, but it actually gives you a little bit more use of that glute. You get a little bit of a longer stride. And so I want glutes. And now you know why I love glutes for this population. And especially for you as a menopausal, perimenopausal person, if you're losing muscle mass, I want as much shock absorption as I can build for you for this system, okay? And so increasing cadence alone often can make folks super bouncy, which I don't love, and it shortens their stride. So I lose some glutes there. So I get the cadence thought process, but I get that with leaning. Anyway, rotation, breathe while you're running. Let that tummy go. And I know, again, it doesn't have to be like, it just needs to not be gripped navel to spine. Give it some ability to move with you, okay? The other thing would be movement variability. And we know that doing some kind of activity with impact is great for bones, but we want you to change directions. We need the bone to have stimulation from different directions so it builds more density. But when we take a day, like when we talk about recovery, we think that we need more recovery in the menopausal transition for our muscles, for those metabolic systems. But rather than think about it like as lengthening just time between sets, we might want to just throw in a day where we're not just doing running is literally just the same thing over and over and over and over and over and over again. And if we have a day where we do a HIIT workout instead that has lots of different directional movements, different kinds of movements, it takes out that repetition for our joints, for our muscles, for our bones, and for our pelvic floor and that complex. So throwing in an alternative workout, that cross-training effect is actually something that could be really positive. And we actually see with triathletes lower CrossFitters and triathletes lower rates of incontinence in those groups than we do for folks that run only. And I think that some of that could be that variability of movement in the training programs of a CrossFitter or a triathlete. So use that like that might be an easy thing for you to implement to help all of your menopausal symptoms and your pelvic health and improve your recovery for your performance. And so sleep, y'all, I'm not going to go through this whole slide, but we actually recognize this is all pre-menopausal, this information. This is on a lot of athletes, like collegiate athletes and things like that. But we actually see a reduced ability to recover if you're not sleeping well. So again, recovery can come if you manage your sleep health. And that can be creating one of those routines at night, drink tea, don't look at your phone. I'm sure you've heard all of it. You may have tried all of it. Sleep is my holy grail. I'm still working it out, but my solutions and your solutions may look different, which is why we have to tailor this. But we do know that without sleep, we don't recover as well, which can basically create cumulative load on tissues, joints, etc. And that's where we might run into trouble. So again, and we also know that helps us, it actually impacts our ability to modulate and pain, and it sensitizes us to our pain, or to potentially, and this is me extrapolating a little bit, but maybe it sensitizes us to a prolapse symptom as well if we're not getting sleep. So we need to sleep, but we need to solve that problem sometimes with the help of some really good patterns and changes in our behavior. So let's talk about integration, and that's where we're going to wrap. And then I can open up to questions. Thanks for indulging me with a little extra time here. And so when we talked about the lengthening of the glutes, lengthening of the pelvic floor, if we use breathing and that interrelationship that we understand, if we take it and use it inside a squat, we can start to pattern the pelvic floor with the glutes. So remember, the glutes lengthen as we go to that foot contact in front of us. And so a squat also lengthens the glute. And so when we are squatting, if we inhale, remember on inhales when the tummy should relax and the pelvic floor should lower, if we inhale as we go down, we're patterning the pelvic floor with its friend, the glutes. We're timing that together. So inhale down, lengthen, eccentrically load, and then concentric, so shortening. We're going to exhale, and that's when the pelvic floor shortens and the glutes shorten. So this is just, and again, this is just patterning. I'm teaching your brain and your body to work in together. And so then we might move to a stagger step. So I get more weight over this. I can do smaller ones and work on speed. I can go up on one leg and work on just that one side. If I tend to have hip issues or, oops, sorry, I'm not done yet. With running on one side, then I might want to work to single leg work. And I know this sounds rehabby, but it's just, we're building a brain pattern, and then we're teaching it, because you can't go out there running 10 miles and think about breathing and timing all this. That's not my expectation. It's to pattern it in so that when you're running, that's what the brain accesses. Okay. So the other thing I actually like for my runners is a single leg RDL, or Romanian deadlift. And so I'm going to do it on this side, so you can see the lengthening idea here. But I'm also lengthening and shortening my other side. So maybe I'll show both sides. So this is a lengthening of the glutes. I'm going to inhale. That lengthens my pelvic floor. I got to let my tummy go. The nice thing about deadlifts is your tummy kind of naturally relaxes. This is why I like this. So I'm lengthened, and then I'm going to blow, exhale, get that reflexive, and I'm going to do it quick. And now I'm getting that quick. I'm working on that, that stride through. Okay, so lengthened, and now I'm getting that, I'm bringing the leg through. So now this actually looks more like running for me. I can load it. I can work on speed and quickness, because guess what? That pelvic floor has got to act quickly in running. And so those are some ideas on how to start pulling in the pelvic floor and patterning it in with the hip, with the low back, with the abdomen, and our breathing. And then finally, for some of you, you need to pattern this in with impact. You need to learn how to put the pieces together with impact. Like, you can't, your brain and your pelvic floor may not be able to tolerate that, or joints. Oh man, I can't show this to you.
I know, I'm so sorry.
It's on my Instagram.
Yeah.
But
I think that's great. I'll pop your Instagram into the chat, and then hopefully everyone can grab it there as well.
I just posted this because I've been talking about prolapse. It's Prolapse Awareness Month, but basically, what I can talk you through it. I do. Maybe you're familiar with like mountain climbers. I like to use plank jacks, so it's like a jumping jack. So when I make them go parallel to the floor and practice impact while they're parallel to the floor. So what that provides is the ability to start to pattern and absorb impact without the load of being upright. So it's a way to sort of grade how much impact you're really getting through those tissues. And then once they can manage that, we speed up, we breathe, we work on all of those patterns. And then once they can tolerate that, I might lift them up on a box or a chair. And then I keep going higher and higher, practicing some of those impacts with breathing. Again, just patterning it in with the expectation that that will become the pattern the brain goes to when you're out on the road. So again, hopefully, I think that's the end there. Yep. And then, so now we can talk questions, but hopefully you understand that, it might be the Kegel, back to our Kegel friend, there is a positive there, and there is nothing wrong with Kegels, but when you're Kegling, that might be a great, like 1 repetition max type response. I may have already said this, and so I apologize. But when we're looking at something like impact, that's where we're talking about just a very different program that we need to create for that person. So hopefully you've got some new ideas, and that you see, maybe some places where you can start to make some changes that would bring some improvement for you, both with your pelvic floor and your pelvic health needs, and then also your athleticism and maintaining that over the lifespan. So does anybody have any questions? Sorry, I'm like, go.
Julie, amazing. I took I don't know if you saw, I was taking notes through.
I couldn't see anybody, so.
No, you could only see me, but I was taking notes. So yes, absolutely amazing. I want to just skip to your next slide, just so. Yeah, for you, because guys, if you are on Instagram or Facebook or Twitter, please follow Julie, because the amount of information, and I just believe this, that if we are giving women and females the information that they need, we can start changing this narrative essentially. So thank you to you. So please, guys, follow Julie, because I've learned so much, and in this hour I've learned so much. The questions have been few and far between, because I'm not sure if I know some people through midday in their work day, so they might have had to have left, but that's also fine. But there are a couple of questions that have come through, so let me ask a few of them. Let me just go back to those questions. I'm going to pop this up onto the screen because this one is slightly anonymous. So she says, hi, low and different mobility on either side of the hip is an issue. Also, more hip issues after menopause, especially after driving, desk work, and gardening. It negatively impacts running consistently. So again, this is very vague, Julie, I know. But is there, because you spoke about the hip, and a couple of people mentioned that they couldn't necessarily see where you're pointing to in the hip, but a lot of what you're saying is glutes, right?
Let me see. Hang on. So it's a little, I usually, if someone sends me something like that, like I have 8,000 questions I need to ask. Are you having those same symptoms on the weekends when you aren't commuting and you aren't on your desk? Is there mobility activities that you're already trying? Like what are, what's at the heart of this that we need to get at? But menopause, and I feel all of you, because I'm figuring it all out for myself. But it changes all the rules. And so there's some, again, it's what else has changed for you? Is sleep an issue in terms of pelvic health? So if I have an asymmetry in how folks are experiencing their symptoms in their hips, I'm going to watch how they do a squat. I'm going to watch how they do a single leg squat, especially if they're a runner. Single leg squats is my favorite evaluation tool with a runner. And that is because I want to see how, and then I'll make them hop potentially. I want to see how do they absorb. And I'm not going to see what their pelvic floor is doing. I'm going to see how the rest of their joints are actually absorbing, right? So I would want to watch you move. I'd want to be able to see how you're using all of these complexes. And I apologize, I don't have glutes on this model, but maybe this would help a little bit. But it's not going to help because I don't have all the pieces of the puzzle here. But basically the pelvic floor is in here and those hip muscles come out from like inside the pelvis and then and wrap around onto the hip. And so they're literally right there. So I would want to know how strong your glutes are. Like, how are you using your hips? I would want to watch your running. I always have folks send me videos. So I don't know that I can give you a solid answer in terms of giving you a solution, but I'd be very interested to see how those activities worked for you. Like, could you potentially work? And I'd be working on rotation. I'd be working on how does your tummy behave? Like there's so many things there that, and you may be overactive. Like if you're experiencing more pelvic health related stuff, a lot of folks go straight to the Kegel because that's all they've ever heard. And it may be restricting your hip motion. And, so there's all sorts of pieces of that puzzle. So it's a little difficult to give you like, oh, you should just do this. I wish I could do that. Oh, I'd be so rich.
Well, I often say that to people as well. I'm like, if I had the answers to all of this, I wouldn't be here doing a webinar. I'd be sitting on an island, sipping a cocktail, and we wouldn't be having to have this conversation. But
But what I do hope, and I am not trying to make light of. I'm sorry, I don't know who asked your question, or diminish it. Like and it may feel overwhelming that there's so many, like, I got to understand all this stuff. But really, to me, it's exciting. Like, I have lots of ways that I can look at how you're doing something and try to find some simple, like, what could we change that might bring a response? Like, what could we start to look at? And I would be interested to see if you tried, I don't know when you asked that question, and maybe it was before I showed like the RDL. And you could try something like that and see if just bringing in that cycling might help with some of those symptoms. Just try it. That might be a place to start. So hopefully that's a help. It's really hard.
Yeah, I think the questions here are going to be difficult to answer because there's so much individuality and so much that goes into it. Can I just say that and this happened in the last webinar we ran as well, where, guys, you must understand that Julie and I did not have a conversation before this. I did not say, please put the RDL into your program, because a lot of our clients, they don't dislike the exercise, but we focus heavily on glutes and hamstrings anyways, just, runners, right? And so I'm so happy that you put that in there, because we call it an arabesque, but exactly, it's the same concept of, RDL, like you're making sure, and both glutes are working. And for me, that was a excellent thing for me to learn, because for me, there's been so much around the pelvic floor that's been more about relaxing and breathing. But to understand what you were saying about the glutes has been amazing. So
it's a beautiful relationship, and really just it's that creating that pattern. So I don't want you just to do glutes either. Like creating that pattern is really beautiful, and once it lengthens, it's got to learn to come back up again. And it's like that's what we're looking for. We got to do both. It's like the middle, folks. So yeah.
Brilliant. Okay, there was another question here. I'm gonna pop this up, and you might have covered it, but I think it's always worth mentioning again. So Laurie had asked, I don't have incontinence issues, but I wake up 3 times per night as I have to pee, which is not ideal. Not sure if this is something that you would be covering, but that again is I guess pelvic health a disorder of some sort, right? Or not necessarily. Or
it depends a little. It's a great question. It depends a little bit on your age. We actually eventually, now here's the thing. It's normal after a certain age, and it's in that transition to need to get up at night to go pee. We're actually designed so we don't have to do that. We're not supposed to have to do that at night. But we've seen it's a normal thing that happens as we age. So we don't get too over crazy if it's like 1 or 2 times a night. But as someone who has to get up to pee too, sometimes it's like it sucks, because then you're awake and then your brain goes, right? And so, but when we look at something like 3 times a night, then we are like, like there might be some other pieces of the puzzle to consider. And I don't know what your age is. I don't know some of these other pieces, but I would be very curious about some other things. Like, did any of those other urgency, frequency, some of those things, did that come up as a, ooh, I've got that, or are you constipated? A lot of folks don't realize that they're constipated. That can lead to getting up at night. We also
she's still Nicole, sorry, she's still here. She said she's 58.
Okay. Yeah. So, but here's the thing. We've normalized it because it happens, but is it normal? I don't know. Like we have so little research. We have so little research, and I'm actually excited to look at my data related to this population. I just haven't had time to analyze that part of the data, but sleep apnea is actually a piece of the puzzle. We actually know that urgency and nighttime trips to the potty go down when folks manage their sleep apnea, goes down significantly. So that might be something to explore. Hormone support might make an impact. It's a little, and it could be like darkening your room. Do you have a dog? Like, there's because my dog didn't get the 411 that they're not supposed to get up at night to pee either. I'm like, what happened? Why are you getting up? Because then I'm up. So anyway, there's a lot of variables there, and some of that is out of scope for me. So I can only offer a little bit. But yeah, that might be something to bring up with your physician, and see if, and especially someone who might be willing to give you hormonal support, and you may already be on hormones, but it's a fine-tuned science as well.
Awesome. Excellent. Thank you, Julie. This is a question from Kay McPherson. She says, thanks, Julie. What is your exercise prescription for patterning exercises? Are we looking at hypertrophy? Are we looking to just get bigger muscles versus endurance for repetitions? Or again, working to fatigue? And again, this is a very loaded question as a SNC coach. There's so many answers there.
Yeah, it depends on your goal, right? It depends on your goal. And is this someone who I'm working with who's like, we're brand new, like this is a new manifestation of this. We need to pattern it in. Usually it starts with neuromuscular. Like this is, so I don't know if that word makes sense outside of the sciencey realm, but that's that early patterning. We look for like 3 to 5 reps. And then I start potentially loading it if I think loading would help with proprioception or mass building or strength building. And then if I'm working for speed, that might look a little bit different, or endurance. There is no way, if you're running 10 miles, that I can do enough RDLs to build enough tolerance. Like I can't do that. So the patterning, that shouldn't last forever. Like you should be able to see some changes with that patterning pretty quickly. And then you might want to start speeding it up, loading it. Like, again, if you start with 2 legs squatted, then if you're getting there, you move on, and then you move on. You know what I mean? Like you move on when you see results, when you're meeting those goals. And so, again, I apologize. It is a bit of a tricky question. I'm so sorry. Everything kind of depends on the goal of the person standing in front of you. But if I'm trying to pattern this in, I might actually have folks interval train by running uphill. So I'm going to interval training, running uphill, walking downhill. So this might be someone who is learning for this. I'm reducing their impact forces. I'm trying to teach them how to get over their lead leg, like that kind of patterning. I might try to start them with intervals running up a hill and then walking the downhill. And that might be a way to just pattern that in. So it depends on how long your hill is. You know what I mean? And I've taught in places where they have no hills. I don't know about and then I have to make stuff up, or use a treadmill. So I apologize. I don't know that I'm answering these questions well, because it's just more There's just a lot we need to understand about each individual. And I think that's actually a really beautiful shift we're making in medicine and in training, is to stop just being like, oh, you have low back pain? Here's 10 exercises. And, or here, oh, you want to build muscle mass? Go do these 3 sets of 10. Or that's not good. I know that's not a good recommendation, but yeah. So yeah, I hope that helps a little bit, but I generally speaking, you'll want to build it with similar to strength and conditioning type planning, like that progressive loading. You're just going to do it with body weight or with speed. It's that progressive overload that you're going to, like, don't hang out there for long. If they've got it, keep moving. Yeah.
I think you're answering that question perfectly. And I think this is one of the things that, well, one of my goals for this was that Kegel, not to Kegel was the catchphrase of what are we doing? But the whole point comes down to that it's not just a blanket approach to everyone. And the equivalent with exercise, it's not a blanket approach that everyone must just be doing X or just doing Y. And everything you've just said there is 100% correct, because it's the most frustrating thing for people to hear. I get that. But the number one answer to all these questions is it depends, right? And this is the key thing for me, is that I just want women to feel empowered that if they are struggling, that they are experts out there to be able to help them. That it's not just a matter of going, oh, go do Kegels or go and do this exercise. Go and find someone who will listen to your issues and understand what you're going through and give you solutions to help you through that. So
and to individualize your care, but hopefully you also heard things like, oh, wow, if I just manage my constipation, that might actually make a really big difference. You know what I mean? And I keep, forgetting to create a sleep routine. Maybe I really should look at that, because I'm not tolerating my runs like I used to. You know what I mean? Like, maybe your sleep is, sleep is the new, like, that's it, y'all.
That's your performance enhancing drug that water allows,
100%. And it is so horribly affected by menopause. Like, and I have I finally found my nighttime cocktail of like magnesium and melatonin, like just the right dosage finally for me, but that's not yours. Like, it may not work for you. Right. So it's really like hopefully it is empowering versus like it's just overwhelming. And I'm so sorry, because I know it's like we don't have enough practitioners. We don't have enough practitioners who understand all this either. So I am on a mission to like empower practitioners and pros and the folks that have the biology, like, do what you can, seek out help. There are practitioners that understand this. I don't actually know if I have folks, I meant to look before I got on here. I have a map on my website that's called a Find a Pro map. I know we have people from all over the world here. And it's folks that have taken the courses that I teach around these ideas. And so if you're looking for someone that's close to you that understands this, you can reach out to folks on that map. It's called the Find a Pro map on my site. A lot of countries have within their pelvic health academies. I can actually send what I have to you. I don't know who else here, but there's a lot of resources out there to help you find someone local to you. So reach out. There are people that can help, but my goal is we got to build up an army of people. And we've never understood that. Just give them Kegels, right? Like, so there, no one cared enough.
And that's exactly the point. And I think that's, this is a starting point. I know we haven't solved the issues here, and there's so many. So there are a couple of questions that did come up, and I'll put those up in just a little bit. I know we are pushing time here, but I think that's the key thing, is that for me, this is a starting point. This is the starting point of just having these conversations. Let's just kickstart it a little bit. So I think that's excellent. So Julie, thank you for that. I want to ask a question. This is one of my questions that I wanted to ask. So I'm 39. I'm not going through perimenopause. But one of the reasons why I have and everyone always asks me that, like, why are you doing this? It's just I've always had such an interest in female athletes. But what is something, and Tracy has asked this question, but and it ties into what I want to ask is, what is some good prehab that you can do? So if you don't have any of the symptoms you mentioned, so me as 39 and I haven't gone through perimenopause, I don't have children, I've never gone through childbirth. Are there things I should be doing to look after my pelvic health now to not have issues later on?
I love this question. And so really it's be aware of your, like, can you find your pelvic floor? Can you tie in? What are you doing with your abdomen? Are you using it in patterns like this? Integrate it into whatever you're doing with your exercise. And so one of I actually do a lot of pregnancy and postpartum. And so prior to the pandemic, I had just started finally getting people to come and see me before they got pregnant. And then we worked through each trimester. And so for a lot of them, they're like, how do I prevent an injury or something happening during my pregnancy? And a lot of it's like what I described in a lot of this stuff is good load management, running form, good running form. You want good run, and what is good running form? That's a whole nother conversation. But are we mitigating impact forces for you? Is there something you could be doing to improve your impact tolerance? But we also know, like we've said, oh, you have the genetic potential for osteoarthritis, you shouldn't be running. Well, we know that is not true. Now we really understand that. We want people loading. We want people doing that. So I think that's such a good question. But really for me, if you came to see me, I would look at what it is that your goal is. And if it's running, triathlon, lifting, yoga, whatever it is, and then looking for ways to improve your engagement with it, and integrating the pelvic floor into it. That's it. And ultimately the goal here is that you don't think about it. You shouldn't be having to think about this. But some added awareness and then of how you're utilizing it inside these patterns is one of the ways that you can use this in a prehab kind of a way. And I don't think you have to do preventatively do Kegels, tons and tons of Kegels. I had so much more content. I had to really work to pare this down. So I went over anyway, but I just read a really amazing article that showed, it compared what the tissues look like. There's a reason why I pulled it out because there's complexity here, but they basically showed that they looked at runners pre 30-minute run, 37-minute run, and then post. And they actually showed that folks with no running related stress urinary incontinence, their pelvic floor increased in strength and power after the run. But folks who had stress urinary incontinence, their strength did not change, but their power went down. But for every one of them, both the continent and the incontinent, all of the tissues sort of hung a little bit lower. So what does that tell us and then the folks that, anyway, there's so many layers to this. So I don't want you to walk away and be like, oh, but that idea that we saw, I think I didn't really hit on it at that point. But when we see the pelvic floor go down and up, Leitner, that study, their team said, we actually might be getting a training effect from running. And so when we see this new information coming out that's indicating we might be getting that training effect for some, right? But some it doesn't. Who are you? Where are you someone who would get the training effect? And my own data, my data supports that maybe the folks that are still running are the ones who are getting the training effect, right? Why are they getting the training effects? And then that takes us down the rabbit hole of genetics and how your collagen is. And so then it's what do you understand about your genetic predisposition? Can we develop testing around that? Blah, blah, blah. There's so many pieces of that puzzle. So I think that we're just at the beginning of this conversation, but really we're just at the cusp of being able to, I think, delineate who might be more at risk, and than someone who isn't as at risk. It's some of that's just genetics, and that's something to be kind of, that's a whole nother conversation. So was that a helpful answer?
No, 100%, definitely was, and I quite like what you were saying around how runners. Maybe that, just in terms of they didn't have that effect as much. And again, the biggest thing I've learned tonight is around glutes, and everything I've heard around pelvic floor and it's all been about relaxing and breathing. But for me, what you explained around the glutes and how if you have stronger glutes, it creates that, because everything around pelvic floor is about the relationship between the pelvic floor and the core and the intra-abdominal pressure. So that for me was amazing to then understand that if the glutes can withstand a lot of that pressure, it takes, a little off the pelvic floor. So I love that.
Yeah.
But you started your answer with finding your pelvic floor. So Helen then said, she said, well, what is the top tip for, how do you find that? I don't think we know. How do you know you're activating, or how do you know that that's working?
There's a couple things you can do. So I'll give you a couple different ways. One is, and this was you may be seated right now, so you could do this, is a lot of, and this is not, I didn't come up with this, but you can roll up a towel. Like, I don't have a towel here, but like you can run up, like it's a kind of a hot dog. This, I don't even know what I'm saying, but, and then put it lengthwise under your perineum. So you would sit on it like this.
I'll join you. I'm going to try to join you here. So I have a towel, right? So
okay, yeah. My model. And then you'll sit on top of it. And just like you're riding a horse. Yeah.
Okay.
Now sit down. You can do it in standing, but and most people are probably seated. So if you sit back down, then you have some tactile, you have some feedback, right? You can feel.
Yeah.
So now let's practice. Like, take and relax your tummy, take an inhale, and try to let your pelvic floor relax, and see if you can feel it heavier on the towel. And then you can lift it away from the towel when you exhale. So inhale, feel it get heavier on the towel, and then exhale, feel it, and you can actually consciously lift it away from the towel. It gives you some feedback. So that's something you can play with. The other thing that I love to do, I call the ski jump. And I do have videos of this on my website. So there's other ways to do this. My camera is not positioned well necessarily for this. But if you stand, so everyone can stand with me. And if you stand, I want you to pay attention to where your weight is going into the floor, if it's going through your heels, your midfoot, or your toes. And I just want everyone to just take a moment. And again, this is self-assessment. And if it isn't already in your heels, I want you just to sort of shift back a little bit into your heels. And while you're there, I want you to do whatever your version of a Kegel is. And I want you to feel where you're getting that sensation. And then what I want you to do is we're going to lean forward, kind of like what I was showing with my patient trying to learn to get her weight over her lead leg. So again, I'm not leaning by bending at the waist. I'm shifting my weight forward from my ankles. And in this position, I want you to do a Kegel. And I want you to pay attention to where you're getting that sensation. And I don't love to use Kegels necessarily, but I want you to close and lift your pelvic floor. So shift back and forth and feel where you're kind of getting that engagement of your pelvic floor. And what often happens, I'm just going to feed some answers. I don't know, and Shona, I don't want to put you on the spot on what you're feeling, but if you're in your heels, often what folks feel, and when they're doing that engagement, is they feel their anus. They can feel their anus tighten. And but when we shift into that forward position, often folks can feel more of a contraction toward the front half of the pelvic floor. And so what happens for folks is they do a lot of work around their anus when they're trying to do their Kegel, but it's that shift forward. It sort of predisposes us to activation toward the front of the pelvic floor. So that can be a new way for you to start to try to find some awareness. Like if the towel helps you a little bit, you can try taking it up against gravity. And because this is where most of us experience our issues, is up against gravity. And so, and when we're more forward over our feet, it gives us more access. That's a whole nother, I'm like, getting my pelvis out. But anyway, but maybe that helps some of you to find, get a little bit more activation. If you cannot feel your pelvic floor move, you may already be overactive. Like you may already be way up here. And so again, it's like your bicep. If I'm like, now give me a bicep curl, there's nowhere for it to go. So you often have to relax, let the pelvic, like take a breath, let it lower, then you can feel it lift. You have to open the door so you can close it. So that's an issue for a lot of folks, especially my runners. They're already overactive. They're already using it way up here. And so they have to learn to inhale, relax the tummy, let it out, then they can feel it come up. So hopefully that's a couple different positions and ideas you can use. Did that help? Yeah,
definitely. And I think just exactly that. I think one of the key things as well, aside from glutes, is overactive versus underactive is such a big concept. And you mentioned, runners being perhaps more overactive than not.
I was really the data that we got, and I mean, and there's so much more, like there's some really interesting findings that we had. And again, I got stuff on that on my site and on my Insta, but it's like we're getting there. And one of the, and I'll just say this, we looked at how all of those symptoms were associated with the runner's impact profile. So we looked at that relationship with running. And what we found was kind of interesting. The runners with incontinence did not have higher impact forces. We were expecting that. And I was like, oh, like, boo. That was what I was like, yay. But what we found instead, the only symptom of any kind of pelvic health, so all those overactive symptoms, we looked at we saw if there was any relationship, so not causal, but a relationship with higher impact forces. The only group that had higher impact forces was folks that had painful sex every time, either frequently or every time. So those are folks that tend to have an overactive pelvic floor. And here's the deal. With painful sex, there's a lot of reasons why folks have painful sex, but an overactive pelvic floor is usually a part of that picture. Like I said, like you could be dry, but you're going to like there's a protectiveness that we have around that part of us. And so that overactivity, that symptom of asking folks, do you have painful sex? And if you're not sexually active, it could be like with tampon insertion, for example. And it's so penetrative sex, if that's painful, that might be a clue to you that you're overactive. Like, so my hope, and again, this is just like with the wee beginnings of like, maybe we have a new screening tool. So rather than only asking your athletes, do you leak when you run? If we could add in just that second question, do you have painful penetrative sex, or do you have difficulty when you have a tampon? Now we have two questions. One might clue us into the underactivity, and one might clue us into that overactivity. So we can do a better job of making suggestions around what we want you to be doing. And again, then I would want to contextualize that with when are you getting the leaks, when are you, all that stuff. Yeah. But that alone might create a new way that we could screen for this and be better about how we're making those decisions, especially for folks that are like, oh, you have a pelvic health problem? Let me just have you do a Kegel. And that isn't really addressing pelvic health. That's cookie cutter thought processes. And so now we could give them a tool instead, like rather than be like, boo, you stink. It's let me give you a tool. Let me show you there's maybe something we could do simply that would help you know better how to handle this with your athlete. So yeah.
Amazing. Julie,
I'm excited to get it out there.
I know we've been going for an hour and 40 minutes, and I'm sorry, we could carry on.
No, it's great.
But let's call it there, because I think it's been phenomenal, and I've learned so much, and I think everyone. I mean, I've just got a message saying, so useful. Thank you so much, Julie. Yeah, parting shot from you. What would be the message you would want to send from here?
Here's comments.
You just see
the whole time. I'm like, I want to see. I think that it really. There's a couple. Just walk away with this. Be hopeful, because there are folks working on this on your behalf, and there's help. Like this, you don't have to have your mom or grandma's future. Like we are working hard to change this from early, like pregnancy, postpartum, and then into these. But y'all, we're working at it. Like there's still not a lot of research. We're trying, but man, there is a lot of pieces of the puzzle, and that is not overwhelming, that's like, yay, we have so many other tools that we can offer. And hopefully this gave each of you some, maybe just a couple pieces that you could start thinking about for yourself, and some motivation to look for some help locally.
Yeah, I think if I can just echo that, I mean, guys, I think this is the key thing, is that if we now are starting to understand very, very wide aspects of what we're feeling, and being able to give you the answers towards all of that, that it's not just as Julie said, a cookie cutter approach, that it's specific. And I think that's key, is that we want females, women, to be heard, and I think that's a key point. So and as Helen says at the end, lights at the end of the tunnel. So that's your hope. Guys, thank you so much for joining. Thank you so much for listening. Really, really appreciate everyone being here. And really, I hope you all got a ton of value from it. If you did, please hit the subscribe button, and we'll be putting a lot more of this kind of content out there. So thank you everyone for joining.
Bye everyone. I'm looking, I had to give it a go.